it and then go back to my natural hello everyone. I'm Stephen Villa. I'm in course Alan Weber. Wave to everyone. I think I know closely. Nice to meet you if I have it. This is the title of my project. It's a novel, streamlined, computer-based version of the Emergency Severity Index triage algorithm and its effects on timeliness and quality. So, just some background on the study. So, the number of people utilizing the ED for care is increasing annually. This is something that we learned. I actually Google imaged ED crowding, and the fourth picture that was up, this is the general, if you haven't been there, check out. But it's going up. This is a graphical representation of this. So as you can see, from 1999 to 2009, this is just basically demonstrating what I just said. The number of people using the ED per 1,000 is going up. And this is across the United States. Contrary to popular belief, most people would say like, oh, okay, yeah, lots of people, uninsured particularly, use the ED as their primary source of care. This graph is just demonstrating the red line here is going through and has the same trend that the previous slide had, that it's going up. This is in millions. And this bar graph here this is the percent of uninsured for this particular year. And the take home from this slide is that this has relatively remained stable, and these visits have gone up. So it's kind of demonstrating that the Affordable Care Act, the Affordable Care Act may address some of this, but won't take care of the number of visits that we're seeing or the rate at which it's going up.
Was that the percent uninsured of the entire U.S. population?
Yes.
Okay.
What's the percent uninsured in ED?
Percent uninsured for the ED visits in base.
Of ED visits.
ED visits, yeah.
No, it's the population. The general population has always been about 15% of uninsured.
I see.
So despite the fact that the 15% is stable, we're seeing ED visits rise, which is one sort of self-evident reason why we shouldn't be blaming these visits on uninsured.
Have there been any changes in the percentage of ED visits that are from uninsured patients?
They're actually lower.
And just to drive home this point more, so this is Massachusetts, which we know passed something similar to the Affordable Care Act in 2006. And you can see that this is similar to the first graph that I showed, but it went up in 2006. So the take home from these slides is that more people are going to the ED. Right? And so can we continue to work the way that we've been working? The big problem is that recent data over the same time period has kind of shown that the highest acuity patients are not seeing providers within the recommended amount of time. And this, I think, definitely can jeopardize patient safety and satisfaction. I'll go into this a little bit further. And even though we're here at Austin UCSF, this is not, it's also seen here. In 2008, Dr. Weber published a paper that showed that less than 50% of the ambulatory high acuity patients were actually seeing providers within the recommended amount of time. And this fraction was actually worse during peak time. So when things are really busy, it's even worse. This is a graphical representation of the first bullet point. So the emergent is the triangle here, and this is the percent of patients completing triage within the recommended amount of time. That's hovering around 60 over the same time period. And then Dr. Weber's paper, this is the main table from that paper, and this is the number. But again, this is the ambulatory patients. The previous slide was all patients presenting, so this was even less of the high acuity patients completing triage. And if you look here at peak, it's 37%, so worse during peak times. So I made this table. This is the way that I think about it. So we have a whole bunch of people. Where we're at right now is we have a whole bunch of people presenting to the ED, and I think of triage as kind of a turnstile. And so this turnstile is moving kind of slowly, and every so often, you know, depending on time X, you get somebody out here and you figure out their triage acuity. The reason why this is a problem is because while people are sitting out here, somebody could die in the lobby while they're waiting if they're really acute and need to see providers. I think, you know, we don't know anything about these people as they sit there. And based on the stuff that I've already said, this is going to get worse. What we want is this turns out to spin faster. And so even though the same number of total patients have presented in this scenario, we know more about these people, and this person, this highest acuity one, can then get to the room and be seen by the primary care provider, or a provider, healthcare provider. So that's why this is a problem. And so before I move into the specific aims, just briefly I want to just give some terminology. So triage, we kind of all know what that is, but it's just the process of determining the priority of patients based on their acuity. Also used when resources are low, which is another issue in itself. And then the emergency severity index, just briefly, it's a 5-tier system where 1 is the most acute. So going back here, that's why this 1 would have been the most acute. And it's the most commonly used system in the United States. About 57% of hospitals in the country use it. And we use it here. This is an example of what it looks like. So first thing, if a patient presents, you say patient's dying, yes, stop triage and get them to a room. It's kind of common sense. The answer to that question is no. Then the nurse, there's criteria that they get trained in, but the general take home is this someone who shouldn't wait? If there was 1 bed left in the ED, would I give this bed to that person? If the answer to that question is yes, then that person is a 2. If the answer to that question is no, then based on the nursing experience, they then ask themselves, based on patients that I've seen like this in the past, how many resources do I think this patient needs? And resources defined by labs, imaging, those types of things. As you can see here, if it's many, then at that point you would take vital signs. This is how the algorithm was written. And if the vital signs were abnormal, then at that point you can consider moving this patient up to a 2. If not, they were a 3. So that's how it's actually, you technically shouldn't be taking vital signs until this point. And then you can see here 4 and 5. So the specific aims of our study were, does an expedited triage process decrease triage time for ESI 1 and 2, the highest acuity patients? And would this, if it does, would this expedited triage process result in any unintended consequences on quality or safety of care? So these are the 2 specific aims of our study. So this is going to be a retrospective before and after study, or a quasi-experimental. And it's going to be done here at this ED, which is a tertiary care hospital, and sees probably more patients with higher complexity than your typical ED. Sees about 39,000 patients per year. And we're going to take everyone who presents to our ED 1 year before the implementation and 1 year after. And as of right now, we plan to exclude those who are deceased on arrival and pediatrics patients. And the reason why we're excluding peds patients is because there was emergency or urgent care changes, process changes. There was a lot of other things happening during this time period, and just the feasibility of including them would make things difficult. So for now, we'll include. So in total, after you account for your typical percentage, about 31,000 patients we'll see, 31,200. So what is this before and after? What were we doing before? So this is a screenshot of what the old EHR, which was a homegrown system, what it looked like. And so the nurse would take all of this stuff, the patient's name, would write down the medications here, write down the past medical history, and do a lot of these things, and would kind of just be writing down or figuring out all this information, and would have that ESI algorithm that I just demonstrated on the wall, and then would composite it all and then figure out the acuity of the patient and send them to where they needed to go. Which, as one could imagine, taking all of this would take kind of a long time. Not all of it, but as you go through, taking a lot more. So this is the example again of the thing that's on the wall. It's just taking a long time. It's cumbersome. And I think everyone here probably has used Apex at this point. So this is familiar. This is what now what the patients see while in Apex, which Apex was implemented, the triage change was implemented. And you can kind of tell that this kind of walks the nurse through the algorithm. They don't really need to look. It has the cues here that are part of the algorithm to kind of prompt the nurse to say, yes, this is category 2. It has some other cues that are kind of specific to our institution more so, especially immunocompromised. We have a larger percentage of people who are status post-transplant presenting to our ED because we're familiar with them. So we've also changed a few things in here just to because they're more specific to our institution. Two other things I'd like to say on this slide is that the nurse still has the ability to choose the triage category. So these prompt the nurse and remind the nurse of of where they should be placed, but at the end they can still choose the triage category. And then the other thing is, I just want to point out this triage complete timestamp. So as soon as something is done in this when triage is started, this comes up. It's a timestamp, and once you click here, it's a timestamp. So that's important for the way that we're going to collect our data. And so our specific aim one, our primary outcome is going to be the median triage, start to triage end timestamp for high acuity patients. Median, just based on the previous study that Alan did, there's just a lot of variation in those presenting, so we'll have to use the median time point. And then secondary outcome will be the proportion of high acuity patients who complete triage within this recommended amount of time, which is probably what we've been talking about. And so we'll definitely look at this too. And just based on the literature, we're going to stratify this by acuity because they have different recommendations. Arrival mode obviously would play a factor if you came in by ambulance versus just walked in. And then, as I've said before, peak versus non-peak has been shown to affect this. So we'll account for all of those. And then our second specific aim, are we missing information? So one of the things is we cut out a lot of info done at triage, or at least the info that you need to write down. So one of the things we have to take or see is the ESI distribution still the same? Meaning, are the percentage of 1s, 2s, 3s still the same across both populations? There's no reason to suspect that they're very different, but are they the same? And we have to correlate it with admission rates because we changed something. So one could guess that the triage algorithm itself may have changed. That may affect the total number of 1s that we see. So if we correlate it with admission rates, then we can make better statements. Other things, unscheduled return rate to the ED that we're going to check for. This is dependent on lots of factors that happen in the ED, but if something was happening at triage, this could suggest that we're missing stuff. And then a big one that I really like, is the adverse med events. As I said before, the nurses were writing down the meds and the past medical history and all those things. And if you remember to the new triage algorithm, they're not anymore. And so we'll go through and see, are patients receiving medications that they're allergic to more often, those types of things. For safety parameters, these are just metrics that we collect, that the hospital collects and is responsible for. So we'll just collect these and make sure that we haven't gotten worse. Hopefully we've gotten better, but who knows. This leave without being seen rate, which is another metric for efficiency. If you speed up the triage, hopefully this number would go down, so we'll be looking into that. The time from arrival to provider. This is actually the thing that we care about, though, as I'll get into on further slides, we'll measure this for sure, but we decided to use the triage, start to triage complete as our primary outcome instead of this, and then room to provider. And I can discuss this a little bit more. And then finally, Press Ganey scores, just a survey that's sent to all patients that come to our ED as kind of a metric for patient satisfaction. So we'll be collecting all this to discuss quality of care. And so just things to consider. So this is a quasi-experimental, and as I said before, there's no reason to suspect that these two populations are very, very different. Nevertheless, we'll still collect the usual suspect information like demographics, where the patients, the ethnic percentage of ethnicity or primary language, all of those things, still the same age. But other things that we have to account for is the health of the patients. Was the population seen before the change relatively the same, at the same health status as the population afterward? And so we'll be looking at admission rates to do that, the total number of patients seen, just to make sure that one of the systems wasn't bogged down more often, as that could affect our outcomes. And we'll also be looking at patients with multiple visits in each time period, the number of comorbidities of a randomly selected population using the Charlson Comorbidity Index. And then, do we have the same number of new patients? So we're taking all of these things just to say that patient-specific, things specific to patients hasn't changed very much. And then nursing staff changes. This algorithm is very dependent on the nursing staff. So other things that we have to account for is whether or not, one could imagine if a whole bunch of less experienced nurses came in to play during one of these time periods for some reason, that could greatly affect our times, just because the learning curve for these triage methods is experienced. So that's another thing that we need to address and just prove that they're relatively the same. And then finally, hospital changes. The fact that the electronic health record changed at the same time as our triage change is probably the biggest problem we have. And the next slide, I'll talk about why we chose our specific times. And then other process changes are things to consider, like the layout of the ED change or those types of things, which did happen. And then are there other studies going on, like a sepsis study? You know, this is a UCSF, so there's tons of research happening, just keeping those in mind. And then this last one is the staff on strike. It was. And so just thinking about that as we move forward. And so I just made this, so this is a metric that that we collect and care about. It's the ED total length of stay. How long is somebody sitting in the ED for? And this red box is what we care about, or the reason why we're investigating this. And we could collect theoretically all of these intervals. Apex can definitely do it. The previous system is a little bit more limited, but it does collect this specific interval. But this slide is really to just talk about the fact that we had two changes happen at the same time. So right now, our proposed way is to just look at the time intervals that we can and compare them across the two platforms. The reason why we chose this specific interval is because this is the only one that had the extra change. The rest of them just had the EHR change, and so we compare them and hopefully see a disproportionate change in those two things. It's not ideal, for sure, but right now it's the best that we're thinking of. And so just the timeline, so that's why we're choosing this triage start to triage end. And just the timeline, right now I'm still in the data collection phase. Apex is a little bit easier to take data from than the original system, but we're still in collecting, so a little bit, definitely on the earlier side than Sept's project for sure. And so we'll be cleaning up the data soon, and then start for analysis after that. References, questions? Any questions? Yeah. I don't have a slide that says questions. So questions?
You should have a slide, or like a picture or something.
Yeah.
I was just wondering what are like, do you know what average triage times are like right now?
For like the US or?
Just, sure, or here.
It's if you're talking about like everyone who presents to the ED, it's around like 40 to 50 minutes is what I've seen. But that's including people who like twist their ankle and like are worried about it breaking.
And that's just triage start to triage finish?
That's our arrival to
arrival to triage.
arrival to triage completion.
Okay.
But obviously, so the reason why, if we go back to these slides, the reason why the percentage is lower is because the recommendation is stricter. So they may be doing, like 15, 16 minutes, which is not good enough, but good, significantly less than these patients who are urgent, but that's still not, meeting. So that's why it's disproportionately affecting those who have the strictest criteria.
So I know I had talked to you about your project before, and with the issue of nursing staff changes, have you thought about how you might investigate that?
Yeah, so there's two different ways that we talk about. We haven't met with a biostatistician yet. I think the easiest way, from my standpoint, would be to just use a model to do it, which we'll get into further. But there is another way. There's like a book that they have in the ED that they don't start, nursing staff doesn't start out at triage. They wait till they get a certain experience level, and then they move them. And I can actually go back and back calculate how long, or what the mean number of months is that a nurse has been triage trained, and see when they've been triaging. So I can go back and calculate the mean, though the easiest would be to use the model, for sure.
Sorry, so with this new triage system, it still doesn't include vital signs up front, and still doesn't, and the nurse or whoever's doing triage still chooses manually which ESI level the patient is in, even after completing everything else, right?
Yeah, so I guess I didn't do a good job of it, but in this, I don't know where it is, but the first one that I showed you, what was happening was a lot of the nursing staff was writing down the medications and the past medical history and those things, and thinking to the algorithm. They actually, I mean, if you go down it the way you're properly supposed to, you're not supposed to take those things. We're kind of bringing everything together and doing it. So they can still do whatever they think is necessary, though the algorithm, the new system walks them down that process more so. That answer your question or not really?
Sorry, so just, do they typically check vital signs before assigning like one of the 1, 2, 3, 4, 5?
If they get to this level, yes.
Okay, then they will.
Yes. But that's the way that the policy is. I mean, they're.
If I can just clarify, in the old system, they did everything on everybody. So everybody got a vital sign, even if they were gonna be a 2.
That's
Right? In this algorithm, we can't say what they're actually doing, that's one of our other issues, but the goal was to direct them that they don't need to collect everything. If the person needs to be put in a room, just put them in a room. And that's what we were trying to emphasize with this.
I was wondering if you've actually had any time to observe the triage process
Yeah.
to see how it matches up with, the Apex layout.
It's going to be interesting the way it plays out because there's going to be nursing variability. Like, the policy is what it is, but people are, especially with the more experienced staff that have their system of doing things. I noticed I had when I went down to the ED, there was one nurse who was recently trained and was kind of going through a little bit more. They're both, first off, incredibly efficient. They assess these patients very quickly and can get through work faster than I can, that's for sure. But they definitely, the nursing staff who's more experienced has their way of doing things. And I didn't see them writing down any medications per se, but just in the conversation, like it's something that is, like past medical histories can be important and the nurse, uses their discretion to ask for that when you're thinking about acuity, because belly pain, it does come into play when you're thinking about what they need. So it depends on the nursing experience from what I've seen, but I mean, at the end of the day,
See, it seems like with such a rich database, you can ask lots of other questions as well that are more ecologically based. Like what have you seen on the wards about literature with weekends versus weekdays, or even seasonality? Have you thought about those as secondary questions too?
Yeah.
Not necessarily the impact of the intervention, but just in general.
We've been cooking up lots of different outcomes. I mean, things that like health disparities wise, all kinds of stuff. We got lots of stuff on the front line. But this is the they're with Apex especially. I mean, we're limited by the previous system for sure, but with Apex you can ask. I mean, you could get like efficiency of the employees on how many times they click to complete a task. Like it's insane. Which I'm probably not efficient.
Does it matter that UCSF Parnassus Center is not a big trauma center? Does that affect your study?
I think it allows for us to not think about time on diversion, because we're not on diversion as much as the general for sure. It changes, the generalizability for sure, but I think the next step of this would be that if we could show something that was promising, we would roll it out to other hospitals that are using Epic and get a more generalizable sample. So like Fresno, for example, there are lots of other people who are using this system. We can be like, hey, check out what we can. So that would be the next step. It definitely is an issue and a good point, because our hospital is very unique, I think. So yeah.